Welcome to our world. This is your global.
Dr. Sostak, who took it from the laboratory to patients. And the title is this, Global Efforts to Minimize Asphyxia. So what has been done? Briefly, antenatal interventions have not really worked well. Yes, selective C-section for C-section for selective cases, yes, but there has not been an effective effort that has been implemented worldwide. So thank you for the invitation. I don't have any conflicts, and we'll talk about the potential for essential newborn care resuscitation training in first-level facility and community birth, so community birth-based birth, to reduce perinatal mortality. We'll look at the contribution of asphyxia to mortality and long-term neurodevelopmental impairment, and address neonatal resuscitation that is highly effective in reducing both fresh stillbirth and neonatal death from birth. So this is a case scenario here that I have. And I'll start in the middle of the story, and I think this is really good when you teach it, teach NRP or any resuscitation program. So you suddenly start in the delivery room when the baby is apneic at birth, severe cyanosis, and no tone. Imagine yourself in Africa. The college-educated midwife is overwhelmed. She thinks the chance of survival is close to 0. That's what she has been taught. And she's been taught that if the baby survives, the chance for long-term impairment is close to 100%. So she observes the situation and then calls the baby a stillbirth. And this goes on and on and on. Some days I've been exposed to 5 or 6 of these babies before we decided to start intervening. Now let's take the same baby. So I have a case, same case, scenario. So what happens now? After training, and what will happen after you train. So this is the usual way to present a case. A healthy 25-year-old woman, 40 weeks, gravida 1, para 0, with normal pregnancy and labor in sub-Saharan Africa. So you as a clinician, you know that if you get a baby who is apneic at birth, severe cyanosis and no tone, and Dr. Sosak showed the evidence, the outcome is good. You do bag and mask, you stimulate first, and about half of the babies or so respond. And then you bag, and then almost 100% of the patients respond then. The study by Jeff Perman was really interesting because he showed, like in 30,000, 40,000 deliveries, that ventilation rarely failed. And when it failed, it was because the endotracheal tube was in the esophagus. So, in fact, we decided in Africa to not teach CPR because we didn't want the physicians or practitioners, nurses, to think they would need this to solve the problem with CPR, because typically once they start chest compressions, they don't ventilate well. So this college-educated midwife training neonatal resuscitation now has the knowledge, skills, and self-efficacy, and knows that this baby has at least a 90% chance of survival without impairment. So knowledge is powerful. These healthcare workers, these delivery birth attendants, are eager to learn. We just have to tell them the right thing. In Zambia, they were taught by neonatologists trained in Western medicine, trained in Europe. And these neonatologists practiced in the UK for years. And when she went back to Africa, she said, we cannot keep babies alive here because too many will get more brain damage. So it was interesting. It was like a self-fulfilling prophecy. So instead of observation, they do effective neonatal resuscitation, including this baby needed bag and mask ventilation. And then you have a healthy live birth. I think this is like so powerful. I think this is should be so motivating for us to go out there and develop programs. And Dr. Quiles will show evidence that you can implement this in the whole country. So, very important to understand that 44%, we mentioned this morning, 44% of the childhood death, 5 years, are due to neonatal causes. And now I show you there, the number one is preterm. Many of those preterm babies die also from lack of breathing efforts. Second cause, intrapartum-related events of birth asphyxia. So now if you combine the half or so of the preterm babies that die from asphyxia, asphyxia is the number one cause really of mortality, okay? So it's a simple solution, very effective. So birth asphyxia is a cause of about 23% of neonatal death and about a third to two-thirds of the stillbirth. A huge study looking at biomarkers, looking at everything they could look, even autopsy in babies, which are rare, but it's a verbal autopsy with minimal invasive biopsies. That study showed that two-thirds of the babies who died were stillbirth. Fresh stillbirth. So the fresh stillbirth were due to asphyxia, two-thirds in that study. And birth asphyxia is the major cause of mental retardation and cerebral palsy. So of all the babies who are sick, the number one cause of brain damage is birth asphyxia. And if you take the whole population, kids that got sick later, they get meningitis or brain trauma or whatever, then it becomes a second cause. But it's the most important mental condition that impairs long term. It obviously starts at birth and continues forever. It has been unknown if implementation of resuscitation training to reduce birth asphyxia is highly effective. So there had not been a controlled trial of training in resuscitation to see if it works. It has also been unknown if resuscitation of babies with birth asphyxia increases the survivors with neurodevelopmental impairment. However, lack of resuscitation is likely to increase handicap among survivors, in addition to resulting in increased death when they don't get actively resuscitated. So I mentioned this slide, but to put it again into perspective, stillbirths are very important, about equal to neonatal death, and most of them, as I said, probably 80–90% are fresh stillbirth. And I mentioned again, if you notice, the biggest cause of death that is not decreasing is birth asphyxia or intrapartum stillbirth. And these are really interesting data because they show that and this is different papers, different times. I put this together, so you see Mexico, there's two representations there. One study that showed more than 50% of the neonatal death due to asphyxia, and one showing Mexico at 20. But you can see in a middle-income country, you can see that asphyxia contributes a substantial amount of the causes of death. And then Donna Halloran, a pediatrician, went to Africa to document what were the NICU follow-up babies doing, how were they doing, if they had asphyxia or not asphyxia. And you can see asphyxia, the babies with asphyxia is the first, in the orange, and you can see that many of them, the majority of them were normal. And then the babies without asphyxia, you see that they had other conditions, but birth asphyxia, the babies, that were abnormal, half of the babies were due to birth did not have birth asphyxia, sorry. I mentioned this, I'll skip it. So one potential idea is to train even the lowest level of perinatal health care workers in neonatal resuscitation and essential newborn care. So we went to the lowest level, as I mentioned earlier, traditional birth attendants, no formal training. We got actually special permission from WHO because it's not recommended that you do it, and to be able to do it in many countries, we got approval from WHO to see if it worked. I told you already the components. This important component, breastfeeding, is extremely important. You show that of the about 2 million deaths per year that could be reduced, nutrition accounts for about a quarter of that. So we work in two settings, in Zambia and a multi-country study that included countries in Asia, South America, and Africa. And there were two different settings. In the Zambia study, we went to institutions, first-level facilities. They were formally trained midwives, and then the outcome was early mortality, 7 days. We then also conducted another study in which we went to communities that were very low resource. So the lowest resource settings in those areas of the country. It's not the whole country of India, for example. It's just Belgavi and Nagpur, and we work there. And we trained all birth attendants, and then there was a early 7-day mortality. Few things of the protocol, I think it's extremely important. All the training was done by local people. We just trained 2 people from each of the sites, so we trained 14 people, and they went back and did all the training. We trained, ultimately, the big study had 3,600 birth attendants, and they were all trained locally. And furthermore, the protocol did not allow us to give them equipment or anything like that. They could not be given anything. They all had bags and masks, but besides that, nothing else. So we used an innovative active baseline design. I mentioned that. It's an innovative active baseline control trial. It's not randomized. This part is not randomized. It's the first ever study. Actually, I mentioned earlier that New England Journal of Medicine editor said, we have never heard about this study. Yes, it's in the book of clinical trials, and it's a design that is particularly helpful when you're doing training of something. But it's a very particular study, and I'll use a slide to show it. And we tested both ENC and NRP. In Zambia, it was 71,000 low-risk deliveries. Here's the facility, and look at the results, about a 50% reduction in all-cause 7-day mortality, about a 33% perinatal mortality, mortality due to birth asphyxia cut by about half, also infection, so a lot of benefits, as you can see here. But let me tell you this slide to show the historic baseline. I mentioned it this morning, but again, the design of the study is that you train first in data collection, and you do all the data collection. And by the way, you have to give bag and mask, or tell them you have to practice bag and mask ventilation. So you have to tell them, if you know how to do this, this is expected that you do it. And when we told them they were expected to resuscitate every single baby, even those who look dead, look at what remarkable reduction, from 95 to 5%. So 90% of the babies that have, in this case it's actually close to 20, survive. Sorry, no, it's 5 of 95, 1 out of 19 doesn't survive. So 5% die without a better resuscitation, let's put it that way. And this was published in Pediatrics. I think this is a very important study. Most of the perinatal mortality occurs in low-level facilities, or low levels, or at home, including birth by birth attendants. And this is the population-based, community-based study. It's a prospective study. The first one is an active baseline, and then a randomized control trial. I'll focus the results on the essential newborn care intervention. So these were 3,600 birth attendants, but they were trained really well. They had to assess fetal heart rate monitoring. They had to score the APGAR, the Ballard exam, and the Ellis neurological exam. So they had to date the pregnancy with the Ballard exam to see if it was consistent with ultrasounds that they are being done in Africa now and Asia, and the Ellis neurological exam. So all were trained by local trainers, and we use the active baseline design with the training in ENC and post-ENC, and then we did a cluster randomized control trial of simplified NRP and collected post-NRP data. So this is in Guatemala, a traditional birth attendant, learning resuscitation. You see that the instructor is a local person also. And these are the results of the study. You see that the third were traditional birth attendants. 19% were family members, and 28% were nurses. And where did the delivery occur? 66% in the home. 10% of those were in the birth attendant home. You see only 25% were in a hospital. And those are some locations have hospitals. In Zambia, it was almost everyone was not delivered in the hospital. These are the results of the study. I showed them early today. That the stillbirth was a reduction, and it was effective in these patients. It's a sort of a joke. In Zambia, we have ambulances. So you can see that little gray thing, that's where we carry the babies to get health care in other place. So this was published in New England Journal of Medicine. So we wanted to see if the survivors of birth asphyxia would have problems. So we wanted to follow them, but we didn't just want to follow them, we randomized them to an early developmental intervention. And you can see here the intervention program is actually delivered by the mother. So we just gave a piece of paper to the mothers every 2 weeks and told them, read the instructions on the paper so they learn how to do it. And you can see here, I'm just showing the intervention and control groups here in the ones with asphyxia. And you can see about a 5-point improvement in MDI and PDI. So it's simple interventions done by the mother. In the West, we many times call these programs brain books. They're brain books. So the lay people can get them. And this was published. And then we look at cost effectiveness. And so we analyze the usual way, cost, and analyze also life expectancy. So the cost is shown here. The bag and mass is the smallest cost. Look at this, $900. The big cost is, in this case, is the part-time nurses that maintain the program. So if you maintain it with your own staff, it doesn't cost much. And this is the results of cost per life saved, $208. And cost for disability adjusted life years is $5. This is like the most cost-effective intervention in medicine. In the West, sometimes people pay $50,000 per daily. That's accepted, for example, in the US. So this is 1,000 times more effective than many adult therapies. And the cost is even lower if you think that you reuse equipment, which can be reused mostly, and you still maintain the 2 nurses that may not be needed. I put even supply replacement because some of the bags break. And you can see there that daily is about less than $2. Compared to other quite effective interventions, you can see there that it is very effective. And the potential to reduce mortality, and this is a paper in neonatology, it's about 1 million lives per year. So take-home message, neonatal resuscitation is highly effective intervention to reduce fresh stillbirth and neonatal mortality. The survivors of birth asphyxia who were effectively resuscitated in low-resource settings generally had normal neurodevelopment. And I didn't mention that the outcome in those, even without the early neonatal intervention, was comparable to the ones that had no birth asphyxia. So the outcome is really good. Low-cost parental-led intervention is effective in improving neurodevelopmental outcomes. I mentioned this. We have here a traditional birth attendant. In some places, the traditional birth attendants prefer to blow with the mouth. And so thanks to Dr. Shostak that taught us that we can do it without oxygen. There's my team again. And finally, a message for you is, if you want to go fast, go alone. But if you want to go far, go together. This is an African proverb. And I emphasize that because I'll say, I could not have done this. This was done by the 3,600 birth attendants who did the resuscitation. It was not done by me. It was done all by them. They take ownership and they are effective. So thank you very much.